Hello everyone, my name is Amir Faraji and I'm going to be doing my presentation on the Barrett's esophagus. So just a little bit of information, introduction about myself. That handsome young man next to Vince Vaughn, that's yours truly. I went to University of Arizona for 4 years for my undergrad where I studied biology, and I am aspiring to become a dentist, and that is what I plan on pursuing after I complete Liberty University master's program. I mean, I love to camp. I've been to a few camping sites here in California and out in Arizona, and I absolutely love to travel. My main goal is to travel, starting in Spain and then ending in Southeast Asia, probably somewhere in Thailand or Vietnam. So without further ado, let's get into Barrett's esophagus. A little bit of history about Barrett's esophagus. Actually, before it became known as Barrett's esophagus, in 1906, a pathologist named Wilder Tileston first noticed peptic ulcers that closely resembled ones that were found in the stomach towards the gastric esophageal junction. Fast forwarding to 1953, there was a surgeon named Philip Allison and a radiologist named Alan Johnston, where they also examined the esophageal lining in 7 patients with reflux esophagitis. And all 7 of those patients advanced to adenocarcinoma. Johnston and Allison later presented this idea to a thoracic surgeon named Norman Barrett, who at first incorrectly described Allison and Johnston's idea. It caused gastric ulcer rather than the presence of the gastric membrane of the stomach. However, since Barrett first published the idea, he was able to name it after himself. So it's not that he was the one who initially discovered it, but he published the idea of Allison and Johnston, and he named it after himself. And so that's how it became known as Barrett's esophagus. And then, as more time passed, the technology to test for such a condition became more advanced. So by 1976 was when the first biopsy confirmed the presence of 3 columnar cell types in the squamous layer. You have the goblet cells, the junctional epithelium, and gastric epithelium, all of which were present in the esophagus and are known to the stomach. Next slide, you have Wilder Tileston all the way to the left. Again, he was the one who first noticed these findings in 1906. Then in the middle, you have Norman Barrett, who was the man who named this disease after himself. And I couldn't find a photo of Alan Johnston, but to the right is Philip Allison, the surgeon who was able to notice that these advanced adenocarcinoma. What causes Barrett's esophagus? Well, you have what is known as gastroesophageal reflux disease, or GERD. And now GERD is the main cause of Barrett's esophagus. So what GERD does is it actually impairs the gastroesophageal sphincter due to genetics, a poor diet consisting of high fat and acidic foods, smoking, or a hiatal hernia. This causes an acid reflux. Now, this acid reflux causes components of the digestive system such as pepsin, various stomach acids such as hydrochloric acid or potassium chloride, and duodenal contents. Duodenal contents consist of lipase, protease, and amylase. All of those enzymes help break down foods after consumption. Now, some symptoms of GERD consist of chest pains, pyrosis or heartburn, chronic cough, laryngitis, and insomnia. Now, when you look at this next photo, to the left, you see a healthy stomach. You see the sphincter's closed, it's tight, and it's separating the stomach and the esophagus. Whereas the one to the right, with a patient who has GERD, you could see that stomach acid, all those contents that I just mentioned earlier, are leaking into the esophagus where it can cause irritation. Barrett's esophagus is just chronic GERD that has not been maintained. So you have 4 stages. You have low grade, you have crypt dysplasia, high grade dysplasia, and intramucosal adenocarcinoma. Low grade Barrett's esophagus is when the nuclei are hypochromatic, enlarged, and stratified. With this change extending to the surface epithelial cells, this results in the loss of serous maturation in the esophagus. After low grade, it can progress into crypt dysplasia. an important biomarker to know when you have transitioned from low grade to cryptdysplasia is by the increased amount of P53 expression. Now, P53 is a known tumor suppressor gene that fights off cellular proliferation. Now, if a patient still hasn't sought any treatment, this can then progress into high-grade dysplasia, where you have increased nuclear enlargement, and you start to begin to notice some architectural loss of the lower esophagus. The lower esophagus meaning around the gastroesophageal sphincter. Again, when the patient has not taken care of this, he can progress into intramucosal adenocarcinoma. Someone progresses from high-grade dysplasia into intramucosal adenocarcinoma, that means the patient has already progressed to cancer. So what do you normally see in cancer? Well, in this case, you see dilated dysplastic glands consisting of ulcerative and necrotic debris, and you also have invasion of the squamous layer in the esophagus. So this just means this patient has already advanced to cancer. And so a histology of what you would normally see. So on the left, you see normal histology, the squamous layer and the esophagus. You could see that it's all neat, organized. This is what a normal histology of the esophagus would look like. Whereas in the middle, you have a patient with Barrett's esophagus. You could see these columnar cells indicated by the arrows, pointing to that these are starting to get enlarged. And these are the cells that you normally find in the digestive system. And then finally, you have the photo to the right, which is a patient that's advanced adenocarcinoma. So at that point, the patient has cancer, and you could see the cells aren't organized. Some are deflated, some are enlarged, and this could become a problem. So who gets Barrett's esophagus? Well, Barrett's esophagus mainly occurs in Caucasian males over the age of 50 years old. It only affects individuals in developed countries, and only about 5% of the population in the United States have Barrett's esophagus. Now, when I was going over all the studies, it had so many different statistics from all over the world, like in places such as Europe, like some places had about 20% prevalence, other places only had about 0.4% prevalence, but in the United States, it was about 5% of the population. Now, what are some symptoms or signs of Barrett's esophagus? Well, generally, there are no symptoms with Barrett's esophagus. Most symptoms actually occur due to GERD. And like I was mentioning earlier, if those symptoms persist for more than 3 years, it is critical to go see immediate help. If I go back to the slide with all the different stages, all those stages occur by just ignoring those early indications of that something's going wrong. So when those symptoms persist for more than 3 years, then it's time to go see help. Now, some signs that a patient has advanced the Barrett's esophagus, like I mentioned earlier, you have the presence of columnar cells, whereas squamous cells should be located. You have erosion of the squamous layer near the gastroesophageal junction, and all of these diagnoses are diagnosed through endoscopy. So now we're going into testing. So you have two different methods of testing. You have the more traditional route, which is endoscopy, and the more recently discovered route, which is the esophageal capsule cytology. So endoscopy, it's pretty much a camera that travels down the esophagus, and it takes pictures of the esophageal lining. It's like a little video camera that goes down there so the physician can really see what's going on. So you have two different routes. You have the traditional route, which is the first method, is the esophageal route. Now, this one is, so like I said, it was the first method ever used in detecting Barrett's esophagus. However, sedation is required because when you insert the camera, a lot of patients have trouble with their gag reflex because it goes directly in the back of their throat, interfering with their epiglottis, which causes major discomfort for the patient. However, there is another method that a patient can go through, and that's the transnasal route. Now, this is not as invasive as going down the esophageal route. This is actually one of the most preferred patient methods because there's no sedation required. So it's as simple as going in, scheduling an appointment, and then they stick a camera through your nose. As you can see in this next photo, right, you have the nasal endoscopy where the the camera actually goes over the epiglottis, and then the physician can guide it down the esophagus and to the desired site. Whereas if you see the photo on the left, or the esophageal endoscopy, the patient is sedated and the physician does the same exact thing, and both of them obtain the same result. Now, this next image, this is what you generally would see in a patient with Barrett's esophagus. So this is the gastroesophageal junction. You could see that the Barrett's esophagus, it's a little more irritated than the other. You could see it's a bright pink, whereas if you see the normal squamous epithelium, it's like a palish pink. So this is clear indication. So this is what they would generally see, and this is a clear indication that this patient does have Barrett's esophagus. Now, another method that was recently introduced in 2007, and that's the esophageal capsule cytology. Now, this is the first non-endoscopic testing method, and there's no sedation that is required for this. It's a capsule that's layered with gelatin and attached to a string. And what happens is the patient swallows it as if they were taking a pill, and this pill goes down the esophagus and it rubs up against the esophageal mucosa. Right after that's the physician believes that it's gone down far enough. They actually pull it out. That's hence why it's attached to the string. And then after the physicians pull it out, they actually take that same capsule and then they examine what type of cells are present in the esophagus. And this is another preferred method. And then going back to that slide earlier, these are the different histologies you could see in a patient. Like I said, if nothing's wrong with them and everything's okay, then you would see this normal image on the left. If they have Barrett's esophagus, you probably see this columnar cells in the middle. And then if they just unfortunately have advanced to cancer, then you would see those cells on the right. So after diagnosis, a patient wants to get treatment. So what are the different treatment methods that somebody can get? Well, treatment varies on what stage you're at in the illness. So you have, if a patient is still in the state of GERD, then they can do a couple of at-home remedies, such as diet and lifestyle changes, reducing the amount of high-fat and acidic foods in their diet. Antacids, such as protein pump inhibitors, which will help prevent the transition from GERD to Barrett's esophagus. Now, if a patient has already advanced to Barrett's esophagus, depending on the stage, they have different types of treatment method. So if you're in the low grade or even the early cryptic stages, a patient can take cyclooxygenase inhibitors. Now, these inhibitors such as aspirin or non-steroidal anti-inflammatory drugs, these inhibitors prevent the transition into adenocarcinoma. Or in other words, cyclooxygenase inhibitors help prevent the patient into transitioning to cancer. Now, if a patient has already advanced to dysplastic Barrett's esophagus or early adenocarcinoma, there's a couple therapy methods that is done actually endoscopically. So you have three different types of ways. You have radiofrequency ablation, which is the most commonly used. And what this one does, it generates thermal injury to the affected site. And then the second method, you have the cryotherapy. Cryotherapy, a simpler version of describing would be it's like freezing off a water, because the physician, they'll put the endoscopy through and they use liquid nitrogen or CO2 and they freeze the area to induce tissue damage. And then so after that tissue damage, they will remove the tissue proteins from the esophagus and hopefully causing it to regenerate back to its to homeostasis of the esophagus. And then finally, you have photodynamic therapy. Now, this one's a little bit more complex as far as the treatment wise. What happens is the patient actually takes a photosensitizer drug, such as profimor sodium or M-tetrahydroxylphenylchloride. After they take this photosensitizer drug, then the physician inserts the endoscopy. At the tip of this endoscopy is actually a laser. And what this laser does is when it travels down the esophagus, the area that's affected it kind of like signals down to the area of saying like this is the affected site. the camera is then inserted down, it's inserted with a laser, and this laser will actually activate the photosensitizer drug, and then what it will do from there is the body will this will induce apoptosis and essentially destroy all the cells that don't belong into the esophagus. So if you look in this photo right here, to the top left, you have the radiofrequency ablation, where you could see that the patient, there's thermal injury to the affected site, as in it's inducing damage of the columnar cells. To the top right, you have the cryotherapy, where you could see that at the tip of the endoscopic camera, there's that's where it's releasing liquid CO2 or nitrogen to freeze it off. And then at the bottom, you have the photodynamic therapy. In this 3-part photo, you have the one on the left, where that's after taking the photosensitizer drug, and it's kind of like highlighting the area that's affected. In the middle, you have the laser, which is going down there, and then to the right of that is where it's inducing apoptosis, and it will essentially destroy where Barrett's esophagus is taking place. Now, throughout my whole research about this topic, one verse that came to mind while researching this was Psalm 107, line 28 through 30. And it reads, "Then they cried to the Lord in their trouble, and he brought them out of their distress. He caused the storm to be still, so that the waves of the sea were hushed. Then they were glad because they were quiet. So he guided them to their desired haven." So Barrett's esophagus, a patient can only get Barrett's esophagus when they ignore all the symptoms that they're occurring while in a state of GERD. Now, a patient cannot know they're in a state of GERD because maybe they just don't know that they have it, or they've never heard of it, and they've never think to go get checked. But when you ignore frequent heartburn that's been persisting for more than 3 years, and you still haven't seen help, that's when you're going to get these kind of problems. So when you go to a healthcare professional and explain to them, like, listen, like this, there's something wrong with me, they'll help you, and they'll guide you to the right way to help better yourself. So to me, when I hear the waves were hushed and he guided them to their desired haven, that's more of a sense of they finally went to go seek help, and this healthcare professional, whomever they are, was able to get them out of pain and help them understand that you have a condition that needs to be taken care of. And by simply just ignoring it, thinking that, oh, it's, I shouldn't have had that burger, I shouldn't have had that smoke, and maybe I'll get better. Sometimes, if you do that early on, maybe it could help you. But when it's persisting like that, sometimes it's better to just be safe and sorry and go see somebody for help. This concludes my presentation of Barrett's esophagus. I hope you learned something of value from this disease and how preventable it could actually be by just even changing one's diet, to a lot more by changing one's diet or quitting certain habits and avoiding certain foods. And yeah, I hope you guys enjoyed it. This is my bibliography of all my sources where I get all this information. And I hope you have a great rest of your day.